I want to introduce Dr. Selma Mohammed, who is with Creighton University in cardiology and advanced heart failure, and also Dr. Mojdeh Talebian, who is our director for critical care at Sequoia Hospital on the peninsula here in California, and also the co-chair of the, I think Mojdeh, it's now the C5, is that right? Critical
Correct.
Care Council.
Yes.
Tell us all 5 letters.
It's CommonSpirit Health Critical Care Council.
There you go. It went from C4 to C5. So that's great. So John, if you'd bring up the reflection, and hopefully, Tom, are you back on? Do you know? Not yet. Okay. So let's go back just one slide, actually. So just so you can see, Dr. Mohammed is an associate professor of medicine at Creighton and medical director and of the CHI Health Heart Failure Program, and Dr. Talebian, co-chair of the C5 and medical director at Sequoia Hospital. So there you have it. So in honor of Martin Luther King, and certainly this week, I like this slide. There's actually 4 reflections on it. I'll just share a couple of them. The top one, well, I'll share more than a couple. Life's most persistent and urgent question is, what are we doing for others? And the ultimate measure of a man or woman is not where he or she stands in moments of comfort and convenience, but where we stand at times of challenge and controversy. And John, there's one more down at the bottom that is my absolute favorite. No, well, maybe it just doesn't show. So, oh, here it is. This one from April 4th, 1968, we shall overcome because the arc of the moral universe is long, but it bends towards justice. And I think that's a great one for us to keep in mind as we go forward. So Tom, I think you're back. Not yet. Okay. So I think we will go ahead and start. As people will remember from our last call, we have focused on post COVID-19 late sequelae. We had an overview from Dr. Bethencourt, followed by an update relative to neurologic late sequelae. And today, the other 2 common areas are cardiac sequelae and pulmonary sequelae. So Dr. Mohammed has a great talk for us, and so we'll have that first. Reminder, there's a raise your hand, a little flag at the bottom, and there's also a Q&A box which we'll monitor, and we're going to have a bit of a panel discussion at the end, and so we'll try to answer questions. Some we'll answer as we go along, and if there are unanswered questions that we don't get to, we usually send those questions back to the panelists, and then we forward them out. So with that, Dr. Mohammed, thanks so much for being with us, and it's all yours.
Thank you for having me, and good morning, everyone. Next slide, please. So cardiovascular complications from COVID are very common, and it could range from having heart rhythm disorders, arrhythmias, myocarditis, coronary artery disease, venous thromboembolism, to advanced stages of heart failure, such as cardiogenic shock. Next, please. Risk factors are prior cardiovascular disease, states where there's hyperimmune activation with COVID, shock states, metabolic disarray, coagulopathy, and immobility. Next, please. So this is a proposed mechanism of cardiovascular complications from COVID, and we'll go through them in a clockwise fashion. So right on the top, it could be direct injury to the myocardium from the virus infection causing myocarditis. It could be a vascular phenomena by virtue of microthrombi or inflammation of the vessels, vasculitis. It could be simply stress cardiomyopathy for patients who are very sick from COVID. There's also a state where there is immune hyperactivation or cytokine storm. This could also cause myocardial dysfunction and heart failure. As far as the coronary arteries are concerned, patients could develop myocardial infarction or type 1 MI, which is classic, or could also have type 2 or demand supply mismatch by virtue of hypotension from COVID, hypoxia, or other metabolic derangement that could cause demand supply mismatch. Next, please. So with that, I will share two cases that have occurred for recently with COVID. This is a 19-year-old healthy gentleman who had minimally symptomatic COVID-19 infection and has recovered completely. 6 weeks later, he presented with high-grade fevers, headaches, myalgias, and malaise. He subsequently developed maculopapular rash, poor appetite, and diarrhea. He also had hepatosplenomegaly. Next, please. So in the ER, his initial presentation showed that he was hypotensive with blood pressure 78/33 and heart rate was 133. He was afebrile, he was tachypnic with respiratory rate of 48 and his SATs were 85% on room air. He had significantly elevated inflammatory and cardiac biomarkers that I will show in the next slide. Next. He was started on broad spectrum antibiotics and pressor support. And his admission diagnosis was severe shock. It wasn't clear at that time what was causing it was multi-organ injury requiring multiple vasopressors. Next, please. Next, please. Next. So his hospital course, a right heart catheterization revealed that he had a mixed distributive and cardiogenic shock. He received corticosteroids, IVIG, and anakinra for a multisystem inflammatory syndrome in children that's associated with COVID-19 infection. His symptoms have improved significantly with normalization of his end organ function. He has also significant decrease in his biomarkers. As you can see on the left, his CRP and SUD rate. His heart function has recovered. His LV ejection fraction improved from 25% to 65%. You can see the top picture, his heart was enlarged. He had pericardial effusion. The bottom picture, his heart normal size and normal function. So his discharge diagnosis was multisystem inflammatory syndrome in children associated with COVID. And as a component of this, he had acute myocarditis. He was discharged on prednisone, metoprolol, aspirin, and oral anticoagulant therapy. Next, please. So the next case is very similar. It's an older patient, a 53-year-old healthy gentleman who similarly had a minimally invasive symptomatic COVID infection, and he recovered completely to present 5 weeks later with constitutional symptoms of fatigue, myalgias, as well as abdominal pain. He subsequently had diarrhea, vomiting, and mild cough. Next, please. In the ED, similarly, he was hypotensive, he was tachycardic, blood pressure 77/46, and a heart rate of 132. He was febrile, and he didn't have respiratory issues at that time. Likewise, he had elevation of his inflammatory biomarkers and cardiac biomarkers. We started on broad spectrum antibiotics and pressors, and his admission diagnosis was septic shock. So a few hours later, he developed acute chest pain, a new ST segment elevation. He was emergently taken to the cath lab concerned regarding acute coronary syndrome and STEMI. And his catheterization showed normal coronary arteries, but severe elevation of his filling pressures. It turned out later that he's in refractory cardiogenic shock with multi-organ failure. He required mechanical circular support with Impella pump, and this was inadequate because he had biventricular failure. So he was put on VA ECMO. He received pulse corticosteroids, and endomyocardial biopsy was performed, and it revealed acute myocarditis. It's on the left over there was acute inflammatory cellular infiltrate. He also recovered within 6 days. He was weaned off ECMO. He was on intermittent hemodialysis for a brief period as he sustained acute kidney failure during his illness, but his kidney function has recovered as well. His heart function has recovered, left ventricular ejection fraction improved from 20% to 70%. His discharge diagnosis was acute fulminant myocarditis associated with COVID-19. So very similar cases, a different age spectrum. Was the first case predominant cardiac involvement in a multi-system state. The second case was pretty much cardiac involvement with secondary end organ dysfunction, and also in a case where there is a heightened inflammatory response presenting a few weeks after recovery from COVID infection. Next, please. Next, please. So for these cases, approach to management would be to provide COVID-specific management if they're actively infected, anti-inflammatory drugs. There is no data to support using them on all cases, so this is a case-by-case basis. They're still under investigation whether there are corticosteroids or specific monoclonal antibodies for IL-6 or IL-1. The sicker the patient, the more likely would be we would give them anti-inflammatory drugs for myocarditis. Goal-directed therapy for patients for their heart failure after they recover, for their arrhythmias, and management of acute coronary syndrome as per the protocol for patients who present with ACS. There are also additional managements specifically in regards to anticoagulation given the hypercoagulable state with COVID-19 infection, and exercise restrictions for myocarditis, very important to avoid vigorous exercises for 6 months for this patient population. Next, please. So when to refer patients to cardiology, this is in the outpatient setting for patients who have had COVID-19 infection. So if patients have any symptoms that suggest a cardiac condition such as dyspnea, palpitations, chest pain, lightheadedness, or have pre-existing coronary cardiovascular disease or risk factor, they should be referred to cardiology for further evaluation. If they have any signs of volume overload, unexplained tachycardia, hypotension, or arrhythmias. And the basic testing that should be obtained guided by symptoms include ECG, chest X-ray, echocardiography, and basic labs. Next, please. So in conclusions, patients with cardiovascular disease are at increased risk of severe disease and death from COVID, but also healthy patients are at risk of COVID complications as well. Cardiovascular sequelae of COVID can manifest as myocarditis, heart failure, acute coronary syndrome, arrhythmias, and venous thromboembolism. Development of new symptoms after recovery from COVID-19 infection warrant appropriate testing guided by symptoms. We don't know much about the longer-term cardiovascular effects of COVID-19 as it nears out, and this remains to be studied. COVID-19 long haulers clinics are needed to understand long-term effects and better care for patients with COVID-19 infection. Thank you.
Absolutely great. Tom, any comments?
I think we'll wait till the end maybe and take some comments back then. Sorry I dropped off, everybody. My internet dropped just as we started, so.
Okay, Mojdeh?
Go ahead, Gary.
Good morning, and thank you for the opportunity to participate in this this panel. As Gary said, I'm a pulmonary critical care, still practicing at Sequoia Hospital. I'm the co-chair of the Critical Care Council at the system level. I was asked to talk about the pulmonary sequela with a specific focus on outpatient management and what to look for when these patients are discharged and or when to start referring them to the specialist. Next slide, please. So just in general, the respiratory symptoms and signs that we see, the dry cough, the congestion, sore throat, shortness of breath, pleuritic pain, hypoxemia. And this is the one that I would like to bring your focus to, because it's a disproportionate to the symptoms. Sometimes they have the hypoxia and they have absolutely no symptoms, and vice versa. Sometimes they feel short of breath and the oxygenation is normal. And then they can have range of radiographic abnormalities. The course, according to WHO, they're mild courses. Fortunately, majority of them are in that category, and about 80% of the patients can be managed, as outpatient. 14% proceed to require some level of oxygen, and those are the severe cases. And then the critical cases are the one that they end up with pneumonia and respiratory distress and ventilator requirement, and that's about 6%. There is a hypothesis that there might be a two-step processes, meaning that they can have this mild disease at the beginning, and they might actually completely recover only to kind of deteriorate about 9 to 12 days later and come up with some new symptoms. And that's why it's important for us to kind of continue watching these patients carefully. And in terms of who will end up going in that direction, it is when they have the ground glass opacity in their chest x-ray, if they have lymphocytopenia, if they have inflammatory markers, elevated prothrombin and D-dimers. Next slide, please. So this is a case presentation. This is a 68-year-old retired nurse who has a baseline mild history of asthma, very well controlled, arthritis, and a remote history of Takotsubo syndrome. A lifelong non-smoker, but unfortunately her husband smokes about half a pack a day. She was sheltering in place since the beginning for 4 months because she was so nervous that she might get COVID. And unfortunately, her arthritis had some issues, and her primary care physician referred her for an MRI evaluation. And when she went to the hospital to get her MRI, she's very claustrophobic. She took her mask off. She had the entire test done without any protection. And 48 hours later, she woke up with this sore throat, hoarse voice, dry cough, and shortness of breath. Being a nurse, of course, she kind of recognized all of these symptoms, and she took herself to the urgent care, and she was tested for COVID and was sent home to be called. And of course, she received a call and was told that her test was positive and to reach out to her primary care physician. So she actually reached out to me. We had a virtual visit, and I asked her to get a pulse oximeter to see what her saturation was and report back to me. I asked her to check her temperature and report back to me. And I told her to continue with her asthma medication with the caveat that bring your rescue inhaler a little bit more, or rather use them more generously. So about 24 to 48 hours later, she actually sent me 2 messages, and she was, having low-grade temperature. Saturations were fantastic, 95 to 98%. The dry cough continued. She was feeling a little bit of fatigue, and at that time, I felt like, we can still manage her as an outpatient. So I said, continue to do the same. 6 days later, we had another video call, and she said that her sore throat is gone, cough is gone, and she had no fever. And in fact, she told me that she was turning the corner. Next slide. So 10 days later, she suddenly woke up with this pleuritic pain, and she described as this stabbing pain, and was short of breath and had the cough coming back, and immediately checked her saturation. It was 94%. She still had no fever. And so she went to the emergency room. They did a CT angio. Obviously, they were worried about the thrombotic component of the COVID, and she didn't have any PE. And there was evidence of mild ground glass opacities bilaterally. They did some labs on her. Everything was pretty much normal, mild elevation of her inflammatory markers. Echocardiogram was done because of her history of Takotsubo, and that was normal. And she was admitted to the hospital because she was just very uncomfortable. She did receive combination of antibiotics, ceftriaxone and azithromycin for 5 days. And because of the persistent cough and this, inflammation of her, increase of the inflammatory marker, she did receive a Medrol pack. Then she was discharged home, and about 2 to 6 weeks later, She continued to have the persistent cough, fatigue. She was sleeping a lot. And at that point, the primary care physician said, why don't you see your pulmonologist again? So by then it was about 8 weeks into this process. And before she came to me, so the question was, what do we do? And that's the focus of this talk. So what do we do is as an outpatient? So I recommended that we get a pulmonary function test before she comes. And so it was very mild decline in her diffusion capacity. Gas exchange is one of the pathology that we see in the COVID, but the rest of her parameters were completely normal. Because she was fatigued, I asked her to do a 6-minute walk test, thinking that she might have hypoxia with ambulation. Unfortunately, that was negative. Because of the excessive sleep, which is something that we do see. Patients are very fatigued and they sleep a lot, but just wanted to make sure that she didn't have any hypoxia. Overnight oximetry was performed and that was normal. And I just threw in a chest X-ray just for knowing that she had asthma and the ground glass opacity that they were seeing, whether or not there is any progression, and that was normal. So in this case, basically, this was sort of a natural history of the COVID in the mild to severe case. She did require a little bit of oxygen when she was in the hospital. So I told her that it's, this is expected, continue with your asthma medication. And I did actually recommend that she starts exercising a little bit, because part of her fatigue and whatnot may have been related to the deconditioning that we see as a result of not doing anything. Next slide. So what are the pulmonary sequelae of the COVID-19? So we know that there are fibrotic abnormalities that we see, and they can start from 3 weeks from the onset of the symptoms, and it's a range of mild to moderate to severe. And the ground glass opacities can actually progress into crazy paving and sometimes into dense consolidation. Abnormal pulmonary function test is another thing that we see, and that's why we recommended measurement. So these abnormalities can be seen at the time of the discharge or up to 2 weeks afterwards. And predominantly it's a restrictive physiology, which is a proportionate decline in the forced expiratory volume and forced vital capacity, and the decline in their total lung capacity. And also we see, again, the changes in the diffusion capacity, and predominantly involvement of the small airways. In the severe cases, what we see is that the high level of the inflammatory markers, which are the CRPs, the LDH, ferritin, they also have a correlation with progression to this fibrotic state. Next slide, please. So this is a sort of a range of the radiographic abnormalities that we see. Predominantly they're bilateral, they're peripheral majority of the time, sort of ill-defined. And then the crazy paving, so the slide on the left bottom, that's the crazy paving. The two slides on the top, those are the sort of a ground glass opacities, again, bilateral. And then at the left bottom, that's a crazy paving if you look at it. And then it sort of progresses into those dense consolidation that you can see sort of difficult to distinguish that from a typical bacterial pneumonia. Next slide. So who gets these sequelae? The short answer is that we actually don't know. We don't know who's at the greatest risk. We don't know who will resolve completely, who will improve, and who will have a permanent effect from these. And what are the side effects of some of the medications that we actually use for COVID-19 treatment? What we know or we project is that if you do have an underlying lung disease at baseline, you have a higher risk of developing it, or your underlying lung disease actually becomes a little bit more exacerbated. Age over 65, obesity. From a SARS and MERS data, we extrapolate that about 50% of the patients with COVID-19 actually develop some form of lung damage. Which can progress into that pulmonary fibrosis. And for primary care physicians, cigarettes and e-cigarettes, obviously we associate those with any kind of lung disease, but there was a study that they actually found that patients who do a combination of cigarettes and e-cigarettes, they have 7 times more likelihood of developing COVID-19. And that in the e-cigarette population by itself was 5 times. So this is an opportunity for us to sort of educate and prevent, and once again, as a pulmonologist, smoking cessation. Next slide. So how long do we look for pulmonary sequelae? We estimate that the survivors will have some kind of abnormalities. And again, it could be a mild and asymptomatic, or it could be very debilitating. If there is no pre-existing lung disease, the severity of the disease and the duration of it sort of determines where we end up going. We have seen complete to near complete resolution up to 6 months in a mild cases. So these are the patients that they were managed as outpatient. 12 months in moderate cases, those are the patients that they end up in the hospital, but just required oxygen, no mechanical ventilation. And we do see persistent lung abnormalities with the fibrosis restriction in the patients that they end up in the hospital, especially the ones that they end up on a ventilator. Next slide. So this is a proposed diagram for how do we follow up these patients as outpatient. And again, I keep saying that we don't know. It's not a criticism. This is a pandemic. This is a sort of a new area, uncharted territory for us, and we are all learning as we're going. So what this is a paper that was published in Lancet not too long ago, and they recommend that we probably should follow these patients a minimum of 12 months. And how do we get from point A to 12 months is that for the first couple of months, especially since they are actively infected, we probably should do a video visit with them and then sort of get, assessment of them. You may need to, see them in person and or refer them. But then at the 3 months mark, you should see them in the office. And what they're recommending is that that's when you will have a repeat of the nasal swab, get the pulmonary function test, do a quality assessment questionnaire, 6-minute walk test, and some form of a radiographic evaluation. And then you do another visit in 4 months, televisit, and then 6 months, 9 months, and 12 months. So that's the sort of a proposed initial or completion. And then after that, depending on if you have any of those patients that they fall into the severe fibrotic cases, then you may need to continue those beyond the 12 mark. And this is still being worked out. Next slide. So in conclusion, COVID-19 sequelae has to be recognized as an adverse outcome of the disease. What I mean by that is that we always talk about, the mortalities associated with this, but this is actually the bigger part of it yet, and not to discount the mortalities, but we will have a huge population of patients that this is what they will live with. So we have to recognize that and come up with some treatment. And the severity of the disease has to do everything with the duration. What do we do as an outpatient to evaluate these patients? A pulmonary function test, 6-minute walk test, overnight oximetry, a form of a radiographic abnormality. These are great tools to sort of prepare your specialist before the patient is referred so that they can actually do the complete workup. How long do we treat them? It is proposed that 12 months is reasonable, but we are sort of like learning it. And this is very important because, as I said, we are all learning. So we are still trying to figure out the management and understand better how do we manage this patient long-term. So we also have to come up with a better definition and classification of the disease based on the symptom duration. And the luxury that we have as a big system is that we have a large population of these patients. And this is a great opportunity for us to actually start sort of prospective evaluation of these patients and come up with, the classification and definition. And as, again, we need to have a well-organized focused clinic so that we can actually manage these patients and for the medical community as a whole to understand the disease. And I finish with this quote that, by Dr. Alwan, who is an epidemiologist physician in UK who actually suffered from COVID-19 herself and had this significant sequela. And she said that we still know very little about COVID-19, but we do know that we cannot fight what we cannot measure. So again, very, very important that we need to really measure the progression of the disease and outcome so that we can actually have a better understanding. And with that, I conclude and thank you very much for this opportunity.
Thank you very much. All right. So I know, we have a little bit, we don't have all that much time, but by the way, thank you so much. Those were excellent discussions, perfect, just what we wanted. And Selma, I don't know if you want to take off your mute and we can talk a little bit. I apologize again.
Sure.
And Gary, I don't know if you want to join us just for a quick, few questions. I think what, Mojdeh, as you said, I think we're all preparing, and I think the news cycle may slowly drop as the acute care process drops off, and all of us across the country, all of us are going to be managing tens and thousands of patients recovering from COVID, and we're not going to be in the news. It's not going to be a big thing, but to your point, Mojdeh, we have to measure it. We have to monitor these patients. And Gary and I are going to work as CommonSpirit. We're going to figure out how to manage this and monitor it together with the help from our colleagues from Creighton and Baylor. And this is not going to go away in 6 months. This is going to be with us for a few years, and we have to learn how to do this right. And we're all going to work on this together. And that's one of the things I've charged Gary to try to get us all together to create a way of a true learning health system. Right? A true learning health system. So, and you both have helped us learn a little bit. And what I love about the cases, and I'm going to do 2 quick questions because I think we don't have all that much time, but Selma, I'm fascinated by Fulminant Myocarditis. When I was in New York managing a lot of cases, we saw tons of these patients. But what was interesting to me about your case was it was delayed, right? It was 5 weeks, the second case. I think it was 5 weeks after the initial infection. And the other, so let me just ask you to comment on that briefly. And also, it didn't look like direct viral infection. It was it's not direct, and we saw this with biopsies on kidneys. This is not about a viral infection infiltrating the myocardium. It's an inflammation response that's now 5 weeks later. I mean, it's kind of crazy if you think about it. Yes. Am I right or am I wrong? Or
yes,
what am I thinking?
It's very humbling that we know very little about COVID, but yes, it was a patient who was otherwise healthy, completely recovered 5 weeks later. It's a presumption that it's COVID associated, given again the heightened inflammatory response that's seen. It's correct that the biopsy showed acute inflammation. We have not checked for the virus in the heart, so we haven't really done viral genome and things like this, but there have been studies that looked at it, and the findings were acute lymphocytic infiltration. So yes, right. It was an inflammatory response in this case.
Yeah, the group that I worked with, they did a series. It was renal biopsies and showed there was no viral invasion in the kidney. So I'm assuming it was thrombotic and inflammatory that was doing the damage. So Mojdeh, your case was fascinating to me also because it was what I love about it is you managed an outpatient first, which Gary and I are trying to get people, and I know it's anxiety producing to manage these folks at home. This was an asthmatic you were managing at home. So I think, hats off. That's great. It can be done. You monitored them closely. And then when there was an issue, you sent them to the hospital. And it worked. And it was good that you managed it that way. One quick question for you. Do you think they really needed to be admitted?
Oh, did she need to be admitted? No. And actually, I think that's one other thing.
I thought you were indicating she probably didn't need to go in the hospital. Yeah.
Well, the second time, because of the pleural.
No, I meant the second time. Do you think she needed it the second time, or do you think you could have got away with it?
No, honestly, I mean, I actually, did a video call with her while she was in the hospital. She lives in a different town, and I was like checking the monitor and I checking the oxygen. I'm like, she doesn't need to be in the hospital, and especially in this time that we are in such a shortage of the bed situation. That's why we're trying to actually improve our utilization of our resources. And that's why the pulse oximeter, I mean, it's such a simple tool. And pretty much as a pulmonologist, historically, I have discouraged my patients from having pulse oximeter because they get nervous.
No, but now you want them to have it, right? Yeah.
Now I'm actually telling everybody to have one. And I think Gary is going to talk about that at a system level. There you go. We're trying to promote that and provide that as an outpatient so that we can actually eliminate excessive admission to the hospital for a variety of reasons, one of which is utilization of resources and also exposing them. I mean,
no, it's better for the patients, right?
Yeah, hospital is not a...
Gary, you're going to give everybody an Apple Watch with a pulse on it?
Yes, they're coming.
Is that the plan, Gary?
Yeah.
They're coming in the mail, all our patients? All right. Gary, any last thoughts on this before we close out?
I did want to make one more...
Oh, go ahead, Mojdeh.
Okay, one more point.
I once again, I wanted to say that this is the opportunity for us as a system. Again, Dr. Mohammed said that we don't know. I keep saying we don't know, but there is no reason for us not to actually put this on our higher priority and sort of, learn from all these massive cases that we have and come up with guidelines perhaps. So thank you.
That's our plan.
Yeah,
Thank you.
there are a couple of chat comments, and I think maybe we could take a minute. One is, would longer steroid taper benefits prevent delayed response on the relative heart and lungs? So I don't know if people have comments about that. I'll just tell you the questions, then maybe you can just comment in general. So that was one. Another person to ask about, is there anything special about e-cigarettes that cause higher risk over regular cigarettes in terms of the inflammatory factors? And there was another question about, what do you tell people in terms of returning to exercise and activities? And I'll just say this last comment was, it says we need to think about other diseases that this also impacts. The American Cancer Society just released data projecting thousands of excess cases of just breast and colon cancer between 2021 and 2030 related to changes in care. So that's a bit off the topic, but I think it's an important point. But so any comments about steroids and exercise and e-cigarettes?
Sure. I could start as pertains to the heart. So there is no role for steroids as a preventative measure because first, we don't really know if it works. We sort of throw the kitchen sink if the patients are really sick, but from the literature of myocarditis, there are only very specific cases of myocarditis where steroids do work. So I would say no, there is no role for prophylactic steroids. And second, these patients may also have recovered completely, so we don't really know who's going to get myocarditis after complete recovery. As far as exercise restrictions, so the restrictions are extrapolated from the ACCHA guidelines, and this is primarily an expert opinion that exercise should be, competitive exercise should be restricted for 3 to 6 months, and before return of exercise, athletes needs to be, or patients who are very active needs to be evaluated to ensure that there is a resolution of myocarditis based on biomarkers, recovery of left ventricular function, and absence of arrhythmias. And we usually do a symptom-limited exercise testing as well. So I would say this is a patient population that should be referred to cardiology for determination of return to work. Thank you.
Great.
So from pulmonary standpoint, in terms of the steroid, the recovery trial was one that specifically answered that question. So in a mild case, especially in outpatient, they actually do worse with the steroid. So yes, that please do not give that. In the inpatient setting, we do use a steroid, and it's a short term. If they progress to the fibrotic phase of this, and you have to sort of do the investigation, there is some proposal that you can reinitiate the steroid at a much lower dose and sort of continue it. But I would say at that point, probably have your specialist to manage that so that you can avoid excessive exposure to steroid. In terms of the exercising, it's a little bit different. So once we know that there is no cardiac stuff, then we actually do recommend mild degree of exercise in the patients with the pulmonary involvement because of the pulmonary rehab and sort of the deconditioning, with very, very close assessment of the oxygenation. And then I think there was a question about the e-cigarettes and why is that? So a lot of hypotheses, but primarily is that there's no regulation. We don't know what's in the e-cigarettes. There's tons of impurities, and the delivery mechanism, that the additives that they have in there, we think that all of those have something to do with the sort of initiation of the inflammation and sort of progression. And I think those were all the questions. Exactly.
Yeah, and I think Gary, maybe we should wrap up. You know?
Yeah.
I think I think maybe excellent cases. I really enjoyed this, and I think we learned a lot. And thank you for encouraging us to think of as a learning health system, I like to say. So we have to collect the data. We can try to pull. It's easier said than done, but we will try, and we will try to learn as a community about these. And that's one of the reasons we're here. Mm-hmm. So, so Gary, I think I'm going to close out with a poem because it was such a monumental week. And I don't know, John, if you can, I'm not a good poem reader, but I'll give it a try. This is a poem by one of my favorite Irish poets, and actually happens to be Joe Biden's favorite poem, and I don't mean this to be a partisan poem. I think it's just a hopeful poem. And Lin-Manuel Miranda read this on the night of the inauguration. So I consider this a bipartisan poem, just in case anyone thinks otherwise. But human beings suffer, they torture one another. They get hurt, they get hard. No poem or play or song can fully right a wrong inflicted and endured. History says, don't hope on this side of the grave. But then, once in a lifetime, the longed-for tidal wave of justice can rise up. And hope and history rhyme. So hope for a great sea change on the far side of revenge. Believe that further shore is reachable from here. Believe in miracle, in cures and healing wells. Call miracle self-healing, the utter self-revealing double take of feeling. If there's a fire on the mountain or lightning and storm, and a God speaks from the sky, that means someone is hearing the outcry and the birth cry of a new life at its term. So this is just, I think, hopefully inspiration for a better year. We get past COVID, but we all know we're going to be managing COVID for quite a while. And hopefully for some calm in the country as we try to go through and manage this together. So thank you, everybody, and have a great weekend.